Chapter 21 Impulse Control Disorders. In our first case study, Jeff, 15, is described by his parents as rebellious to the point he is really impossible to control. No matter what approach we try, he's always been like this from the time he was very small. We're at our wits' end. In fact, Jeff's parents are not the only ones concerned. His history shows that from the beginning, in kindergarten, teachers and authorities have documented Jeff as spiteful, vindictive, and physically aggressive. Our first condition is oppositional defiant disorder, and this is defined as an angry and irritable mood, along with defiant and vindictive behavior. The APA differentiates between emotional, behavioral, and spiteful, vindictive behaviors. This system is important as emotional symptoms tend to be linked to current or future mood, and anxiety disorders, while spiteful and vindictive behaviors, are predictive of future conduct disorder and delinquency. These children may experience social difficulties, conflicts with authority figures, and academic problems. Typically diagnosed around the age of 8, the condition usually affects males more often than females, and is a common comorbidity alongside ADHD. There are many risk factors for oppositional defiant disorder, such as that genetic component, a family history of mental illness, numerous neurobiological causes, along with those physiological influences such as a reduced cortisol reactivity level to stress. Also, cognitive issues such as negative symptoms that are acquired from the condition, and environmental influences such as a dysfunctional family life at home. Jeff, who's diagnosed with oppositional defiant disorder, is taken to the principal's office after assaulting and injuring another student. Which comment the adolescent most likely to make? A. I lost my temper, but it will not happen again. B. I'm sorry and embarrassed that this happened. C. I failed my math test and guess I was just having a bad day. Or D. So what if the kid was hurt? I should have beat him more. And that answer for oppositional defiant disorder is D. This is a conduct disorder is a persistent pattern of behavior in which the rights of others are violated and societal norms or rules are disregarded. The behavior is usually abnormally aggressive and can frequently lead to destruction of property or physical injury. These individuals initiate physical fights, bully others, and may steal or use a weapon to intimidate or hurt others. Next would be conduct disorder. This is a persistent pattern of aggressive and destructive behavior. Others' rights and societal norms or rules are disregarded with a lack of remorse. The complications can be everything from academic failure, school suspensions and dropouts, to juvenile delinquency, drug and alcohol abuse, and even court involvement. This disorder is going to have a lot of contributing factors, such as comorbidities, genetics, neurobiological, and a lot of environmental influence as well. Intermittent explosive disorder. I think I'm diagnosing my own kids in this module. This is an inability to control aggressive impulses and leads to problems with interpersonal relationships, occupational relationships, legal entanglements, and physical health issues such as hypertension and diabetes. Comorbidities include depression, anxiety, and substance use disorders, antisocial and borderline personality disorders, along with ADHD and other disruptive disorders. Other comorbid conditions include individuals with intermittent explosive disorder have been found to have higher than normal levels of inflammatory markers. Intermittent explosive disorder is associated with that loss of neurons in both the amygdala and the hippocampus. Two serious problems related to impulse control disorder are pyromania and kleptomania. Pyromania is the repeated setting of deliberate fires, whereas kleptomania is the habitual stealing of unneeded objects. And while these are not impulse control disorders themselves, they are related to the condition. Application of the nursing process. As with many of our conditions within mental health, suicide risk is going to be a top priority, as long as using those specialized assessment tools and helping the patient self-assess their own issues. Under self-assessment, there could be many common negative attitudes, such as a belief that the patient is choosing not to get better, or a belief that concerns for safety may be exaggerated. The nurse has an ethical and professional responsibility to provide equal care to all of their patients, provide empathy, and consider the patient's environment and history. Along with risk for suicide comes a risk for violence, a risk for impaired impulse control, and a risk for extreme aggressiveness. I spent some time working pediatric mental health, and it was one of the most challenging specialties I worked in. It can be children from very sad situations. It can be very difficult to control and treat. The treatment should always be patient centered, with the patient always an active participant in the care that they receive. And it's also a collaborative effort, keeping every member of the team on the same page and making sure that everyone's involved in working together. For our implementation, we're going to include psychosocial interventions along with teamwork, safety, seclusion restraint as a last resort if necessary, and provide the necessary health teaching and health promotion to each individual patient. There's going to be a wide range of pharmacotherapy and medications that could be effective here, depending on each patient. Everything from Depakote to Abilify, Risperdal, SSRIs, mood stabilizers, or even beta blockers. There could also be a wide range of psychological therapies that could be effective here, with that cognitive behavioral therapy at the top of our list, but also combined with trauma-focused cognitive behavioral therapy, psychodynamic psychotherapy, parent-child interaction therapy, parent management training, and social skills training. Jeff, who has oppositional defiant disorder, says, "My therapist doesn't understand me. I want to see someone else. Should this client have the option to change therapists?" That answer be A, always, B, sometimes, depending on the situation, C, never, since manipulation is part of the disorder. And that answer is going to vary by the patient, but B is probably the wisest approach since a lot of judgment calls are required and are dependent on each case's unique factors. There's going to be a lot of dilemmas. There's going to be a lot of different factors and variables go along with each of the patient's care. Working pediatric mental health can be extremely difficult. Puberty is a tough time for everyone, and when you start combining in poor family dynamics, poor environment, and along with mental health issues, and it can be very difficult to treat. But anyway, that's all I've got in this chapter. I'll see you in the next slides.